Welcome to The Explainer. Today, we're diving into something that needs to be on every clinician's radar: infectious keratitis. And let's be clear from the start, this isn't just a red eye. This is a fast-moving, vision-stealing emergency, especially when your patient is a child.
So, picture this. It's a scenario you're going to see 100 times. A parent rushes in with their kid, saying they have pink eye. But is it? Because telling the difference between a simple conjunctivitis and a dangerous keratitis, that's one of the most important calls you can make. Get it wrong, and the consequences can last a lifetime.
Okay, this slide is absolutely key. It breaks down the big differences. First, let's talk about what the patient feels. With conjunctivitis, they might say it feels gritty, uncomfortable. But with keratitis, they're going to tell you it's true pain, and they can't stand the light. That's major photophobia. Next up, vision. Pink eye, it really shouldn't affect their sight. Keratitis, on the other hand, almost always causes blurred or decreased vision. And finally, look at the redness itself. It's not just everywhere. Keratitis often causes something called a ciliary flush, a deep, angry ring of red right around the edge of the cornea.
So here's how we're going to break it down. We'll walk through how to diagnose it, take a tour of the nasty pathogens that cause it, really zero in on kids, and then wrap up with how to manage it and when to call for backup.
All right, let's get into our first section. How do we go from just a suspicion of keratitis to being certain?
There's a 4-step framework here that you really have to follow. Number 1 is history, and you have to be specific. Do they wear contacts? Do they sleep in them? Shower with them? Did they get poked in the eye, maybe while gardening? Next, always get a visual acuity. It's the vital sign for the eye. Then comes the slit lamp exam. This is really where the action is. And finally, the magic trick, fluorescent stain, which is going to light up the problem for you.
And boom, here it is. This is why that little strip of orange dye is so powerful. You put it in the eye, shine a cobalt blue light, and any little break in that top layer of the cornea, the epithelium, just glows this brilliant, almost electric green. It makes the invisible totally, completely visible.
Now hold on, you don't need to culture every single ulcer, but you have to culture if the problem area, the infiltrate, is big or right in the center of their vision. You also culture if it's not getting better with your first-line treatment, or if it just looks weird, like it has feathery edges that make you think of a fungus. And for sure, if the patient's ever had corneal surgery before, you culture.
All right, time for section 2. Let's meet the usual suspects, the rogues gallery of bugs that cause all this trouble.
First up, bacteria. And when you hear bacterial keratitis, your brain should immediately scream Pseudomonas aeruginosa. This is the classic bad guy for contact lens wearers. Sleeping in contacts, topping off solution instead of using fresh stuff, rinsing with tap water, all of that is just rolling out the red carpet for this bug, and it can destroy an eye incredibly fast.
Next, we have herpes simplex virus. Believe it or not, this is the #1 reason for corneal transplants in the US. It's usually a flare-up of an old infection. The dead giveaway, the thing you have to look for with fluorescein stain, is that classic dendritic ulcer. It looks like a beautiful little branching tree, but it's incredibly destructive. Okay, fungal keratitis. It's not as common, but you've got to have it on your radar, especially with the right history. Think about a farmer or a gardener who gets a tree branch in the eye. On the exam, you're not going to see those nice sharp borders like a bacterial ulcer. Instead, think fuzzy, feathery, with maybe little satellite spots nearby.
And finally, this nasty protozoan, Acanthamoeba amoeba. This one is all about contact lenses and contaminated water. We're talking swimming pools, hot tubs, even the shower. The textbook sign is this ring-shaped infiltrate later on, but an early clue can be these perineural infiltrates, where you can actually see inflammation tracking along the corneal nerves.
You need to burn this quote into your memory. This is the single biggest clue for acanthamoeba. If your patient is in absolute agony, just off-the-charts pain, but you look at the cornea and think, that doesn't look that bad, that mismatch is a massive flashing red light. Your suspicion for acanthamoeba has to skyrocket.
Okay, let's pivot and focus just on kids. Because when your patient is a child, the rules and the risks are a little different.
This right here is a clinical rule to live by. A child who clamps their eye shut and flat out refuses to let you look is not just being difficult. That's a side of extreme pain and light sensitivity. Your differential has to shrink immediately to the worst case scenarios, a foreign body or HSV keratitis. Now look at this number, 13%. It might not sound huge, but when we're talking about our tiniest, most fragile patients, it is incredibly important.
So what does that 13% mean? It means that in newborns with a systemic herpes infection, about 1 in 8 will have it show up in their eye. That red eye might be the only clue you have that this baby has a life-threatening systemic disease. That's why neonatal keratitis isn't just an eye problem. It's a full-blown emergency that needs systemic antivirals, not just drops.
We also have to think globally for a second. In many parts of the world, measles can be devastating to vision. And when you combine measles with malnutrition, especially vitamin A deficiency, which is already the biggest cause of childhood blindness, you get a perfect storm. The cornea can literally melt away, leading to perforation and total loss of the eye.
All right, let's land the plane here. We've figured out what's going on. Now what do we actually do about it?
You're going to hear ophthalmologists talk about fortified antibiotics for bad bacterial ulcers. Don't let the term intimidate you. All it means is that the pharmacy specially mixes up super concentrated versions of antibiotics like cefazolin or tobramycin. We do this to get a really powerful punch of medication right where it needs to be. And treatment is intense. We're talking drops every hour, around the clock.
Okay, the big question. What about steroids? This is such a high-stakes decision. Used correctly, they can reduce inflammation and scarring. Used incorrectly, they are a disaster. So when can you cautiously use them? Maybe for deeper inflammation in stromal herpes, but only after the virus is under control. But here is the do not pass go list. You never use them for active, replicating epithelial herpes, and you never, ever use them if you even suspect a fungus or a acanthamoeba. It's like pouring gasoline on a fire.
If you take one single thing away from all of this, let it be this sentence. This is not something that can wait until morning. The clock is ticking and vision is on the line.
And that brings us to the final, most crucial point. Your job is to suspect this, to do the initial workup, and to pick up the phone. You do not manage this alone in the ER or your clinic. Early, urgent consultation with ophthalmology is what saves sight. Period.
So we'll end with a question for you. You now know the red flags. The next patient with a painful red eye walks through your door. What's the very first thing you're going to ask them about how they care for their contact lenses? Because honestly, that conversation is often the most important step you can take towards saving someone's vision. Thanks for joining us.